Good morning, everyone. Please welcome NCSD Board Chair Audrey McDuff King.
Hello, good morning. How is everyone doing? I can't see any of you, but I'm assuming you look nice, so good morning. So I'm really grateful that people actually showed up for our 8 a.m. plenary because I was a little nervous. I'm a morning person, but I know most people are not. So thank you so much for being here. I think it's going to be great. So as we kick off our second day of STI Engage, I want to be sure to highlight our engaged ally Roche partner. So Roche's support of STI Engage has been tremendous, and we're grateful for all of the work they're doing to expand the diagnostic space. So can we just give them a round of applause? So today we're going to do a deep dive into STI testing, and specifically self-collect testing with my dear colleague, Dr. Preeti Pathela from the New York City Department of Health and Mental Hygiene. I can't imagine a better way to start thinking about the future of shaping the nation's health than exploring the new innovations and technologies that might lead us into a healthier future. So thank you again for being here this morning. I hope you enjoy your second day, and we're gonna go ahead and get started.
Please welcome Dr. Preeti Pathela.
Good morning. It's exciting to see so many of you show up this early in the morning for a session, but not surprising since it's exciting but not surprising. Not surprising because this is obviously a very hot topic, and we're going to spend about 90 minutes discussing it. In a bit, we'll hear from a panel of seasoned public health practitioners talk about real-world implementation of STI testing using self-collected specimens outside of a clinical setting. But to start things off, we'll have a primer on the state of such remote testing from Dr. Barbara Vanderpool. Dr. Vanderpool is a professor of medicine and the director of, professor of medicine and public health at the University of Alabama at Birmingham, and the director of the UAB STD Diagnostics Laboratory. She's been in the field of biology, epidemiology, and diagnostics of STIs for 40 years. Her behavioral research focuses on delivery, utilization, and implementation of STI diagnostic technologies. Dr. Vanderpool also recently served as the president of the International Society for STD Research, or ISSTDR, and as a past president of the American Sexually Transmitted Diseases Association, ASTDA. Please welcome Dr. Vanderpool.
Good morning, everyone. For those of you who don't know, I have some voice limitations, so I'm going to do my best, but you're going to really have to pay attention for me. So, I was tasked with talking about remote testing, and I wanted to contextualize this sort of in a journey. And like all things, the journey is the adventure, but most of us want to get to the end. And I think the kids are screaming, "Are we there yet?" And no, not quite, but we'll get there. So let's talk about how we can get there. Let's see if this works, or if this works. And there we go. I do have a long list of disclosures that I want to share with you. I work with a lot of companies and a lot of different private agencies because I think public-private sector collaborations are the way to go forward. And I've been doing this since long before COVID, but I think COVID really emphasized how important it is for public health and academia to really engage with the people that can help us get the tools that we need to make good quality healthcare decisions. So this is the road that I want to talk about. I've got pride colors up there for you, so yay, everybody. Rock. Okay. I'm not going to talk a lot about clinician collection and lab testing because I think y'all know how that routine works. And I show a divergent path toward the end. But we'll talk a little bit about self-collect in clinical settings. We'll talk about self-collect of only genital versus anal, rectal, and throat. We'll talk about direct-to-consumer testing. Self-collect, which is where we want to get with the blue pin, self-collect lab-based testing in non-clinical samples of all sample types. Right now, that's the place we're trying to get. But there's the divergent path, which is actually self-testing. And of course, I think we want to get there too. And there's another divergent path that I didn't put on here, and it would come lower down, and that would be point-of-care options. Now, the reason I didn't put these on here is because the point-of-care options at this time will still mostly happen in clinic settings. And we're really talking about getting away from clinic settings. So that's why I left those off of this conversation. So what you see is we were muddling along the road okay, and we kind of hit a barrier, and we've run into some blockage and some detours. So our job now is to think about why these barriers exist and how to work around them. So I'm sticking with this metaphor if it kills you all, because once I start, I gotta stick. So we're gonna do the map key, and we're gonna do definitions. And I really feel very, very strongly about this, that if we in public health are not clear in our language, the consumer can get confused, and that is not in our best interest. So when I'm talking about self-sampling, we can divide that into self-sampling in clinical settings, which for most things we have approved for genital testing. In non-clinical settings, there's only one assay that has approved genital testing for chlamydia and gonorrhea. Roche just recently got an approval for self-testing or self-collection for HPV. That's still prescription-driven, though, as far as I'm aware. But this is often referred to as home collection. I don't call it that because we might use it in other places, like in housing shelters, like in substance use centers, and other places where people might come in and want some sort of quasi-health care, and that they could benefit from self-sampling options to get STD screening at the same time. Self-testing was that purple dot on the previous slide, and again, that's where we want to get to, but we are not there yet. And when we use the language inaccurately, people call me all the time and they go, Bobby, I saw there's a self-testing assay out there. How can I get it? And I said, you can't unless you're talking HIV. That's the only self-testing that we have available right now. So be careful in the words that you use, particularly when you publish, because you can give people the wrong impression. Direct-to-consumer focuses on those assays that one can get through their own initiative. So a person can go online. I went on Amazon the other day, no problem. I can get all kinds of tests from Amazon. An interaction with a provider is probably not going to be part of that process. And as a consumer, how do I know what I want to order? It becomes quite confusing. And so direct-to-consumer is its own sort of little niche. But then there's remote testing, which I want to talk about most. And that's testing that I like to contextualize as remote testing via either a public health agency or via telemedicine. And usually because we have a provider at the other end of some communication mechanism, the user can get input about what tests are appropriate, what sample types are appropriate, and how to manage care if they have a positive result. So right now, that section in the lower right is our goal. So self-collection for genital only. A long time ago, people used to say you have to prove to us that vaginal swabs work as well as endocervical samples. It took us 20 years to convince the FDA that they can stop asking that question. Vaginal sample types have been the recommended sample type for molecular testing for chlamydia and gonorrhea since 2009. I still speak to people all the time where they say, yeah, but I'll just get an endocervical swab while I'm in there. But in so many settings now, women aren't getting a full pelvic exam. And so don't say you're not going to test them because you're not doing a pelvic. Go ahead and let them self-collect their own vaginal sample. So that's, we had to also then prove that self-collected worked as well as clinician-collected. We're finally to that point as well. The agency is no longer saying that we have to prove that both work equivalently with doing poolability studies and doing randomization of clinician-collect versus self-collect. We can just do any and all vaginal swabs and they count the same. So that's a real step forward. Now that's not true for rectal and throat samples yet. So that's one of our problems, and we'll get to that in a second. But I want to put an asterisk here that collection devices, the swab you use or the urine cup with a buffer to stabilize it, those are devices. Those are not lab-developed tests. A test generates a result. A device collects a specimen. So while the LDT rulings have thrown a lot of people up in, scrambling to figure out what they have to do to respond to that ruling, in fact, devices were never allowed to have that sort of discretional enforcement. So all devices have to be reviewed and cleared by the agency in order to be sold. Now, unfortunately, this is all an artifact of clinical studies, because what we know is that when you're collecting 4 or 5 samples for comparison purposes during a clinical study, you have to have a clinician do that so that you have good quality samples and so that you can manage the order of randomization. So these are artificial designs that then don't allow us the opportunity to have self-collect claims, especially for anal and throat specimens. This is an area that represents an opportunity for change. This is something we can push back on and should. So I would argue that we really need to push forward to making this happen. I do make a note down here as well that there is one laboratory that has received claims for a self-collection device, but it's a whole system through to resulting that can be used remotely and sent into their lab. But that's only one lab. And we can't afford to have every lab in this country have to go through the process of gathering data, submitting it to the FDA, waiting for review, and then instituting the test once it's approved. If we have common sense data to show that it really can work, then we need to go forward. So I put a word in here about what we demand from industry, because I find this is kind of interesting. A lot of people don't interact directly with industry because they feel like it's a disconnect from their public health obligations. I would argue that we really need to continue to work with industry like we did during COVID and have in the past before that, because we have to remember that when we're asking industry, for example, it was really hard for people to get claims for extragenital, and those claims are all clinician collect. So now we cannot go back to industry and say, oh, by the way, we need you to do those $6 million studies one more time so that we can get a self-collect claim. There's no return on investment for that. So just be mindful that when we ask for something, the onus cannot always fall on industry, and that's where we have to do something to make this whole process more reflective of our needs in the public health arena. The other thing that we want from industry a lot is we want new pathogens or rarely tested things like low prevalence AMR. So if we want to look at gonorrhea resistance, which is an important topic, but if you ask a manufacturer to develop a test that is going to be positive in 0.1% of 0.4% of the population, those numbers are tiny. So again, until we can get regulatory changes to allow us to use banked specimens rather than patient-collected, prospectively obtained samples, some of this is just going to be problematic. So these are expensive studies, and we really have to think about, we have to prioritize what we really need, and we have to ask industry to work with us to get there. Okay, so change topics now to direct-to-consumer testing. So direct-to-consumer testing has been available for a very long time. The first reference that I give you here is from Charlotte Gatos and her group from 2010, when they evaluated direct-to-consumer options available via the internet and found that they had pretty poor quality results. Some labs didn't send results back at all. Some labs sent back incorrect results. And of the labs that sent back correct results, they were almost all public health labs. Give yourselves a hand there, right? I mean, you guys are doing it for the right reasons, and you're doing it the right way. But you have regulatory barriers that make it hard for you to do this. So this was considered a really exciting opportunity to level the playing field, right, and reduce some inequities. But it's not happened that way at all, because these tests are cost prohibitive. They run between $80 and $300, and if you're doing 3-site testing, it's more in that $300 range. And then there are people who don't have access to the internet, so ordering these and following up with the results is not simple for them. There are people who don't have privacy to receive these kits in their home. So all of these issues have made this an ideal solution, but hasn't been realized. And then, as I said, there are bad actors out there. When we looked at labs with an interview with, I think, 23 labs that were offering internet-based services here in the country, most people wouldn't give us their data. They wouldn't tell us what assay they were using. I mean, what does it matter to you? If you're using the Roche assay, tell me you're using the Roche assay. If you're using, but I think what's happening is a lot of times people are using lab-developed assays because they're less expensive. But if that's the case, then we need to understand their validation claims, right? So they need to be sharing data with us. And then I've put a couple of references down here at the bottom, but lack of follow-up and reporting is a concern. Cannon and colleagues wrote an article a few years back explaining 3 case studies where people were told they had syphilis or HIV, and no follow-up was done. In the case of the person with HIV, in fact, when they finally got around to confirmatory testing, the person didn't have HIV, but it was months later until they did that. People with syphilis were, out and about without treatment for months. So the possibilities are there, but we haven't realized how to make these work to our advantage. So those were the things on this side of the barricade that we have access to today, but what's back there on the other side of the road closed sign? Well, no sampling devices have claims for anal or throat self-collection, and this is true even in the clinic. Again, I've mentioned this is an artifact of clinical study design, but is that distinction meaningful? Is there any real biological plausibility to think that a person can't self-sample their perianum? I'm pretty sure y'all know where it is. I'm pretty sure you're not going to put that swab in so far that it kills you. I mean, I'm just really not sure, what the concern is here. But the distinction exists. It's just really unclear to me where the perceived risk is here, but it must be very low. And I did mention the cost-prohibitive nature of getting these extragenital sample claims. One of the studies was actually done with a group that we had put together where 3 different companies worked together to share a clinical study so that they could pay for only a third of it. And they shared the data. They all worked wonderfully together. And an academic organization actually owned the protocols, so the agencies couldn't control it. But everybody got claims from that study. This is another model we need to be thinking about. Are there things that we can do either through public health agencies or through academia that would help us get the claims we need to move forward? But without claims, labs, compliant labs, I want to call it that, compliant labs are hesitant because they live in a regulatory world and they have to maintain their funding, right? So I use Alabama as an example because I'm from there. And so this is an example where our county health department was running people through who did not have symptoms, but allowing them to self-collect their own anal swabs, sending them down to the state lab for testing. Somehow the state lab was made aware that these were self-collected. Everything came to a screeching halt. We were no longer allowed to collect those samples. And Anthony Merriweather is here somewhere in the office. He can tell you the horror stories. This has been going on for a year now because people, but nobody at the health department that sees the patients has enough rooms or providers to do clinician collect for all these patients they were trying to serve. So where are we putting the harm? We're putting the harm on the patient instead of this level of uncomfortableness in the lab. And so this is where we need to think about what can we put in place to correct this situation. Okay, and then using provider-driven remote testing. As I mentioned, there's 2 ways that you can do this through telemedicine, but telemedicine is unfortunately time-consuming and expensive, and it generally, not always, but generally requires that you have a third-party payer. But you often can't get, if you say, I'm a man and I'm on PrEP and I want my quarterly screening, well, you're not symptomatic, so they're not going to be in a rush to set up an appointment for you. And so then by the time you come back to it or think about it again, the moment may be lost. And this is certainly not a solution for un- or underinsured people. So if we start thinking about making sure that we're being equitable and we're really reaching the populations that are underserved now, telemedicine is probably not the ideal option, although it's one thing to have in the toolkit. But public health agency managed programs really are the way forward. So whether it's your state health department or a local health department that manages the program, they support the selection of good quality labs. The public health agencies do their due diligence. They talk to the labs. They try to find out whether the labs are focusing on the appropriate pathogens, what sample types are acceptable, and then also because of the relationship the agency has with the lab, they make sure that we get information back for reporting of notifiable diseases and patient management and expedited partner therapy as well and surveillance. So for all these reasons, The public health managed programs where if you're under the age of a public health agency, then you're eligible to receive these online ordered kits. They get sent back into the lab that's supporting that, and then the results go back to the public health agency. It's a great idea, but we still have regulatory problems to help us get there, including this self-collected problem. Oops. So why aren't we all doing this? Well, first of all, lack of claims for non-clinician collected, as I just mentioned. But mostly I'm going to say cost, right? Because it costs money to send these kits out. You know you don't get a 100% return rate. I do think we have to stop looking at 100% return rate as sort of our metric. What we have to be looking at is how many more cases did we identify and treat than before we started this program? And you're not going to stop your clinic-based efforts, so it really is more people, right? It's in addition to what your routine efforts were costing. But we need sufficient public health funding to make these programs a reality. And we also need third-party payer, say that 5 times, buy-in, because if they won't pay for this, then a lot of people aren't going to get the testing done. So the question really is, how can we offer the right test to the right population? So not every pregnant woman out there needs anal and throat screening. But every man that's having sex with men does need 3-site screening because the infections can be anywhere, right? We just really need to think about what's appropriate for each population we serve. Some populations, like where we live in Alabama, have very high trichomonas vaginalis rates, so we do trick on every woman. We actually do trick on every man at our health department clinic because that's where they're getting it. But there are some places where there's next to no trick, and so in that setting, don't offer it. Don't spend the money if you don't see it. But these are the kinds of things that the public health agencies are very well equipped because you have the surveillance data to make well-informed, data-driven decisions. So I think that it's important to think about changing recommendations, and I hope you're all aware of this, but if you're not, countries in Europe have been offering remote sampling screening for decades, with nobody dying because of it. So we have to assume it's relatively safe. However, a lack of population level impact, and especially these data are coming out of the Netherlands, and concerns about AMR, particularly in gonorrhea, are changing the evaluation of cost effectiveness. So in the Netherlands, they've already got a proposal in place to stop asymptomatic screening of all women, and they will likely also stop screening men on PrEP, because there's very little return on investment in these populations in terms of the numbers of cases that they're finding, and what they're really looking at is, can you show an overall decrease in the population level rates by doing all of this testing? And the answer is, so far, they've not shown that. So they're really thinking about, for cost reasons, shutting all this down. So now we're talking about gearing up a program that would be mostly focused on trying to get services to asymptomatic people who hadn't been able to get annual screening. But maybe we need to consider what's going on in other countries and say, who do we really need to be targeting? And who do we offer these services to again, have the most bang for our buck? And should remote testing be offered to symptomatic people? And I leave this one to you as a thought so that when the question and answer series come up, you can really put your 2 cents in worth on this, because many people say that symptomatic people should not be screened with remote testing because it takes too long. Well, it takes about 4 days. And the reality is, for many people, if you live in a rural area, you may not get to a clinic within 4 days. They may have a clinic that only exists once a week. So is there a downside for those people? Again, know your population, know what services they need, and offer the appropriate services. Oops. And then to get to my little purple pin, self-testing, that's woohoo. But, you know, how many of you, just go ahead and yell the word no if you don't want people testing at home? No. Yeah. Well, I respectfully disagree. And I'll tell you why. Every year when we see the data, it says, okay, let's just say there were 3 million cases reported of chlamydia, reported to the CDC in year X. But because of that 3 million cases, we know there were probably closer to 5.5 million because we know that we don't detect them all. So if you have people who are already not being tested and already not being treated, even if you got half of those people to use an at-home device, and even if only half of those people followed up when they had a positive, how many more cases did you just find, right? So we need to look at it from a reward perspective. We're not trying to replace all clinical care with self-testing, but what we're trying to do is reach as many people as we possibly can. So we really need to think about reaching those people, using point-of-care tests and over-the-counter tests. I think that if some people could do an over-the-counter test at home, then would they want to order a remote test to confirm it? Maybe, because it would still keep them from having to go into a distant clinical setting. So, or would we use remote testing and/or lab-based testing to do AMR testing for those people? So there's lots of options where we're going to take all of these puzzle pieces and we're going to mix and match them. And we're going to mix and match them based on the populations that we serve. So this is a never-ending journey. I worked with somebody years ago that in 1995, when Roche actually got claims for their first PCR assay, he said, "Nah, this is done. We have all the diagnostics we'll ever have or need for chlamydia." And I said, "I respectfully disagree." So, you know, we're not really done. But many paths are possible, and we can get around these barriers. We need force of will, and that will needs to be translated into political will, policy, and funding. And we don't need one size to fit all of us, and we just need to understand the ramifications of the different options that we have. And then, of course, we need to support new and ever-evolving technologies, because when we have new and better technologies, we'll make these tests more affordable, faster, more accurate, and we'll find ways to remotely link people to services. Okay, this is the last slide that I have, and I'll leave it up here until somebody drops it off. But basically, I think what you all need would be a checklist to understand what your population are and what the questions are you should be asking about your population to understand what testing is most appropriate for you. And for each of those populations, which tests should you be offered? For each of those tests, what are the best sample types for that population? And then what do you need to know about the lab, right? Because the lab for most of you is a black box. I like to say I work in a black hole. But you can ask labs, good quality, respectable labs will open their books to you. They'll show you all of their data, and they'll tell you exactly how they do what they do. We've got nothing to hide. And so always start with your APHL labs and go out from there to find people that can show you what you want and show you how to get the services that you need. But I think if we can develop a checklist, maybe it'll make it a lot easier for people to start implementing these newer strategies. And with that, I'm going to leave you. Thank you.
Please welcome back Dr. Preeti Pathela.
Back with my esteemed panel here. And before we get started, I just want to quickly thank David Harvey and other NCSD organizers for asking me to moderate this session. I'm from New York City, where we love a race, we love a competition, we always want to come in first. And yet when we started exploring at-home specimen collection options or remote testing options for STIs in New York City, this was back in 2020, we found that there were state laws and regulations that really made this very challenging for us, since all specimens obtained in New York State have to be tested by a lab holding a state clinical laboratory permit, and that includes test-specific approvals when required. So now we have options with vendors that are working with validated labs, as well as experiences from people like everybody here on the stage who have already implemented programs, and they can provide obviously very great insights. And so I was just really happy to have the chance to kind of cull these questions for all of you. And we're going to have about 30 minutes for the panel discussion before we turn it over to the audience for questions. So start thinking about what you would also like to ask our panelists. But to get started, we will ask you all, each of you, to tell us a little bit about who you are, what you do, and your work with remote testing. And we'll start right here to my left with John White.
Thanks very much, Preeti. My name's John White. I'm what you would call an MD, so I'm a specialist clinician working in STI and HIV medicine in Northern Ireland and the Republic of Ireland. Now, don't let the accent fool you. I'm actually Australian, so I should be saying g'day. But I trained and specialised in Sydney before moving to the UK, and for the last 20 years I've been working over there. I work across 4 different health districts. 2 of them are in Northern Ireland. So if you think about the island of Ireland, it's separate from Britain, and about the top quarter of the island is Northern Ireland, which is part of the UK. Capital is Belfast. I work in the northwest, a city called Derry, and another city there called Coleraine. And I also work in the counties of Donegal and Sligo, which is in the Republic of Ireland, which is the bottom part of the island, which is part of Europe. And so it's all very confusing. But if I wasn't busy enough doing that, I'm also working part-time as one of the medical directors for Preventex. And Preventex is an English-based company which is the largest provider of online postal self-sampling services in the UK. And I'll call that online testing. Bobby's already gone through what that means. And Preventex, we have over a decade of experience. We've done 15 million home or online tests, and it's great to be part of this panel and share some of that experience.
Thank you. Esmeralda?
Hi, good morning, everybody. My name is Esmeralda Quintero. I work with Eastern Idaho Public Health, a local health district in Idaho Falls, Idaho. I've been with EIPH for 8 years. I started out as a senior RN, and my current positions are epidemiology program manager and disease intervention specialist. My role with home-based testing is to follow up with abnormal test results, investigate and provide education and treatment to individuals and their partners. This is my first time at STI Engage, so I'm so excited to be here with all of you, and I'm excited to give you my information today.
Sure.
All right, hi everybody. Thank you all for being here. Thank you NCSD for the invitation. Thank you Bobby for leading us. My name is Charlie Peterson. I use he, him, el pronouns. Happy Pride Month. Also, I'd like to celebrate the first female president being elected in North America, in Mexico. And lastly, I'd like to honor the Anacostans, or the Nacotchtunk, the Piscataway, and the Pamunkey, upon whose lands Washington, D.C. now exists. Great. So I'm the Director of Business Development and Community Engagement at Neelix Labs, a CLIA-certified lab and diagnostics company in Chicagoland in the northwest suburbs. You probably know O'Hare, so we're by O'Hare. I'm the highest non-governmental member of the Illinois HIV Integrated Planning Council. I'm on the board of directors at AIDS Foundation Chicago and a board at Howard Brown Health, an FQHC and the largest LGBTQ+ health provider in the Midwest. Now let's talk about self-collect kits. Neelix basically focuses on intentional collaborations with local CBOs, so community-based organizations, and local health departments to create tailor-made, affordable solutions that are accessible. Right now, we're working with several organizations in Chicago and in rural Illinois, in Quincy, to create multi-organizational networks to address priority population healthcare needs and to capitalize on syndemic approaches between HIV, STIs, mental health, and harm reduction. Also, as we heard yesterday, due to the paucity of STI funding, we're more and more involved not only in policy and advocacy on aldermanic, city, state, and federal levels, an example of which is the Illinois bill that we call the HIV TLC Act, which mandates that carriers and Medicaid provide coverage for home HIV or remote HIV and STI kit testing without cost sharing, very important. But we're also very active in collaborating with our partners to look for funding solutions. And I'd just like to say very quickly, because I do the squirrel and shiny thing, respectfully disagree also with folks who were saying no earlier. We have a clinical comparison study between gold standard on-site collection and collection from individuals in a remote setting. And the results we're getting show that it's basically identical. Thank you.
Hello, my name is Alicia Steines. Good morning. My name is Alicia Steines, and I'm one of the senior public health nurses from Lynn County Public Health, which is located in Cedar Rapids, Iowa. I follow up communicable diseases, enteric infections, sexually transmitted infections. Been with our county health department for over 7 years. My colleagues and I initiated expanding STI testing services and options for our community members in partnership with NCSD through the Check Yourself program in 2022. Additionally, we received NACCHO grant funding to expand that home testing to pharmacy locations. We've partnered with 9 local pharmacies, 7 in rural locations, 1 that has a population of more foreign-born or non-English speaking individuals, and 1 pharmacy that was directed or provides more services to individuals with mental health needs and substance misuse issues. Prior to this grant, though, our remote testing was only by mail-in ordering.
Thanks, Alicia. So I have some questions for each of you that kind of get more at the logistics of your programs, but I want to start with something that's a little more global and really top of mind for us, a high priority in the field of STI, and that's related to ensuring health equity. So remote testing is employed, we know, to reach more people not currently reached by STI programs and service providers. Do you think that this is a health equity strategy that is working? And are there signs of any unintended consequences in terms of exacerbating existing disparities and how we might, would be interested in your thoughts about how we might address those and kind of course correct for them. And we'll just start in the same order since, to give Alicia a break, yeah.
I think with online testing services, there's this concept of the digital divide, and everyone always talks about it, and in that, this is a type of testing that's just not going to be accessed by certain parts of the population. And in our experience in the UK, we don't have a lot of evidence that that is really happening to large cohorts of target populations that we feel really need access to testing. It's popular, people like it, people use it, and we get very good data from our services. And if you look at our Sexual Health London program, which is a massive program that covers the whole of London, and year on year over the last 5 years, we've seen an increasing proportion of tests that are going to the LGBTQ plus population, to racially minoritized communities, to young people. And so they are using this testing, and it's bringing them into care, it's engaging them. And most importantly, it's freeing up capacity in clinics to see those people who want or need to be seen in clinic for clinic-based care, or for people who can't access online testing. And for instance, in my area, we're very understaffed, and we have people using online testing, and it takes them out of our clinic population, and it frees us up to be able to do work that we feel is more important. For instance, one of our nurses goes out on an outreach bus once a week with a public health nurse, and they provide bus-based STI and bloodborne virus testing and contraception for the homeless population, which is a population that definitely wouldn't necessarily access online testing. So, I don't think that there's really good evidence that it's missing large chunks of the population, but what it does provide is choice, and choice is really important, and there's lots of different ways that people may want to access their sexual health care.
Yeah, Esmeralda, I mean, your perspective would be very different, obviously, living with a very different population than what John deals with.
Yeah, I think I agree with him. I think it's a very popular resource right now. It provides a fair opportunity to allow individuals who want and need testing, but probably won't come into that clinical setting. I think it's equitable that there's no socioeconomic barriers, there's no income guidelines. Anybody can come in and have this resource available to them.
So yeah, we feel that self-collect tests are definitely a tool that addresses health equity and accessibility. As mentioned, we work with several CBOs, and there's one particular LHD where numbers are showing that kits are working and people are adopting them. For this one LHD, we've been seeing that there's just as much demand from rural populations as urban. As for the second half of the question, upon closer examination of the kit landscape, though, we find that many kits are cost prohibitive, and oftentimes getting kits paid for by carriers can be challenging. As Theodora Wee last year at the STI HIV World Congress in Chicago stated, testing options must be available and accessible and affordable. That's the most important part. Sometimes people are like, $20 is cost prohibitive. That's one reason why we work with our partners collaboratively to create tailor-made pilot programs looking for funding. We also work together to reply to RFPs, NOFOs, VIV positive action grants. Costs should not be transferred to CBOs, especially given their limited staff and budgets, and it should never trickle down to their clients.
I'm going to mirror what a lot was said up here already. You know, remote testing from a public health standpoint for our county is a health equity strategy that is working. It really allows individuals to test discreetly in their own homes. In Iowa, even though Lynn County is the second largest county within our state, we still only have a population of 230,000 individuals. We also serve a lot of rural counties that neighbor us. And, you know, those surrounding counties, there may not be a primary care doctor's office. There may not be a brick and mortar for individuals to go to. So our program had partnered with pharmacies because those are located within these rural areas. And so individuals with transportation barriers, individuals can seek out testing either through a home delivery service or by picking up at a local pharmacy discreetly. Also, our program allowed us to reach a pocket of individuals pocket of population of individuals we've never reached before that identify as swingers. That is a population that our health department has not engaged within testing, so our home program has allowed for that. Also, individuals may know a friend or a relative that works at their local clinic if they have a local clinic, or their mom's best friend goes to coffee with this lady. So, you know, allowing individuals to have that option for discrete testing is a health equity strategy that's working.
Thanks. John, this question is for you. So there are variations from state to state in this country. And we generally understand how healthcare and public health systems work here in the US, but you are from the UK, and so could you just help us understand, in the most basic sense, how your health system works and how remote testing fits in? And I know that you have great success with high uptake and acceptability, and how that might kind of translate here for our setting as well.
Great. So in the UK, we have the National Health Service, the much envied NHS that a lot of my US colleagues seem to be aware of. And this is a universal healthcare system that's free at the point of delivery, and it's been available in the US since 1948, and it is just something that people take for granted there, that they don't have to pay anything for healthcare, and they don't realize how lucky they are. It is an issue at the moment because, after a decade of Conservative government, the funding of the NHS has become less and less year on year, and that's creating similar issues to what you've got over here. Every health district has its own public health STI clinic or sexual health services, and the funding is distributed locally by the local health authority, and so some services get funded more than others. Now, the online testing programs are part of that system. So even though we are a company and we do the testing, almost all of our testing is done on behalf of the NHS. And it is free to the service users, so they can access anyone, for instance, in Northern Ireland or the Republic of Ireland can go online and order a free test kit, get sent to their home or address of choice. They take their samples and it gets posted back to a centralised lab for testing. And then they're linked into care if they need any additional services or if they test positive for an infection that requires treatment. It's really fortunate for us to have free testing, and I think that it's a challenge in lots of areas of the US where that's not necessarily available. And as other speakers have mentioned, the cost to the service user, even if it's a small amount, can be prohibitive. And so we're very fortunate in that regard to have that. I'm not sure how much longer we'll have that, and it does create conflict between the clinic-based services and the online testing, because even though it's part of the same system, the clinic-based services often resent the funding that's being put into online services. But the commissioners of the service, they know that it's good bang for their buck, and generally speaking, it costs about half what it would cost in a clinic-based service to perform a sexual health screen. And so it's an ongoing, it will be an interesting times ahead. We're hopefully having a change of government in the next couple of months, and that may hopefully start to redress some of the funding issues. But
okay, great. I'm going to switch gears, and I'm actually going to go down to that side of the panel to talk about Chicago and Lynn County. You focus particular attention on gay and bisexual men and other men who have sex with men for your programs, and it seems like you're honing in on some best practices and lessons learned when you conceptualize this as a population-specific program. So could you talk about some of those best practices? Do you have plans and capacity to roll this out to other populations? And what would it look like to scale remote testing to serve everyone? So we'll start with you, Charlie, and then we'll move over to Alicia to address this.
Okay, thank you. So in addition to GBMSM, which I'll just say MSM normally, we focused on collaborations with queer, Black, African American, Latin, Hispanic, and of Spanish origin groups, so LHS+, trans and gender diverse groups, migrants, refugees, asylees. Also, we have some projects with the sex club and bathhouse scene. We work with several organizations in Chicago for females and other individuals in re-entry from the Department of Corrections. And Alicia, you reminded me of something that you said before about the swingers. Also, like with the bathhouse and sex club groups, there are private sex groups that we can also connect with. So that being said, there's a program with a few of our partners that is Black, African American, gay, bi, and same gender loving focused. It's called the Mind, Body, and Soul Health and Wellness Circle. We'll be discussing that this afternoon at 4 p.m. in the Lincoln Room on the concourse level. The MBS, as we call it, is a collaborative effort between 6 queer, Black-led, and Black-facing organizations in Chicago, with 2 of them being faith-based organizations. And more recently, there's an ally organization that's been added on. This program is built to expand holistic communities of support and resources for Black MSM in an effort to engage and re-engage and maintain Black MSM in a range of health-related services with wellness coaches, personal training, mental health, health navigation, faith and spiritual wellness, yoga, nutrition, cooking classes, massage therapy, even at like community events, there's Zumba. So by engaging in all-around wellness, there's a certain level of trust building that you're creating with community. And once there's enough trust that's been built up and you have enough time logged with people, right, because there are serious concerns from certain populations about health providers, et cetera, more serious health conversations can take place, like community-specific health concerns, diabetes, cardiovascular, et cetera, and then leading into sexual wellness and health. So one of our dearest partners, Project Vita, who's in attendance at this conference, is not only part of the MBS and is Black-led, but is more LHS plus facing. The goal of Project Vita is to apply the learnings from the Black MBS and through a culturally informed lens, apply that to the LHS plus community, as much of their staff is LHS plus. So Neelix is ecstatic to continue growing our relationship and our collaborative efforts. In addition, I just want to take a little minute. One of our trans and gender diverse partners in Hyde Park is currently thinking of ways that we can work together to improve and normalize both HIV and STI testing in creative ways by leveraging social media, community influencers, and champions. Lots of drag queens out there. We've got drag queen bingo tonight with culturally relevant messaging. So one of the discussions is, how can you really make that connection with people? How can you like bridge that gap and like bring people in? And one of the things we've been thinking about is creating an ad campaign with 3-site testing, and then something that these individuals do in their daily lives. So let's take putting on makeup, because a lot of the trans and gender diverse community is putting on makeup, right? So do that and also show that you can take a 3-site self-collect in about the same time that you can put your makeup on. So that really transcends, it humanizes testing, and it shows that timeframes really aren't that daunting. Thank you.
Thank you. To piggyback off of that, our program at Linn County Public Health, the only restriction for our at-home test program is individuals do have to be 18 years of age and older and without symptoms. And that's really limitations due to the company that we've utilized through the Check Yourself program. Anyone would be able to obtain a test kit. However, individuals that are under the age of 18 or that do have symptoms currently should be seen by a healthcare provider. Is there something else going on? Is it not sexually transmitted? But just some background in regards to our current program, Linn County Public Health, we offer testing services. We have a full-time MD. We have a full-time nurse practitioner for testing. We also have outreach coordinators that provide STI testing services outside of our 4 walls. They engage individuals through testing at homeless shelters, through the correctional centers, the detention centers, on the streets, at the park, at the homeless camps, at our local libraries. They also coordinate certain events for testing, like through Pride or Get Yourself Tested through our 4 local colleges as well. But to scale up our remote testing options, we've worked with our local Sexual Health Alliance of Linn and Johnson counties, and we've also worked with our state partners and our state disease intervention specialists to increase that awareness, increase the education of our program. We've also worked with advertising campaigns with Commando for LGBTQ plus individuals. We have noticed when we are not advertising, our testing, individuals seeking out our remote or home testing options has declined. So that is a big piece in regards to our program. Also, sustainability. What are we moving forward? Working with our state lab, working with our state partners to sustain the remote testing kits, increasing our capacity statewide. Currently we have grants that are covering the remote testing programs in Iowa. We all know that funds are limited, but we'll continue to seek out grant funds and to maintain this option for our clients.
Thanks, Alicia. You mentioned disease intervention specialists, and I'm interested to know, Esmeralda, from you, how they are kind of implementing your program in Idaho, and kind of what resources are needed for additional resources that are needed that are specific to that particular workforce.
For DIS, some additional resources that are needed specific to Idaho would be, like we've talked about, extra genital testing kits. I know Bobby had mentioned that that's a limitation in all areas. So, but I think that brings a big barrier to individuals who don't just participate in vaginal sex, but also oral and anal receptive sex. Unfortunately, we've been able to keep up with demands, but in order to be able to provide more testing off-site, we definitely need to increase our staffing capacity. And so that's another resource that we would need to help with that.
Okay, so we are almost coming up on time for audience questions. I did want to get to 2 other questions that I have for the panel, but I think I might just save one of them for our wrap-up at the very end, and just and talk about this one, which is that all of us have seen the proliferation of remote testing companies and increasingly see targeted ads for direct-to-consumer companies. For those of us in public health, we're always kind of struggling with being realistic and not super aspirational, considering the constrained resources we have, but this really puts us in a new position of building a direct and often exclusive corporate relationship. There are opportunities and challenges, of course, and so I'm interested in knowing about general strategies for picking a particular vendor, not necessarily for you to name any vendors, but just if we were to have a checklist or tools, what would be helpful for local programs to have in order to make those very kind of difficult choices. And why don't we start, Alicia, with you, if that's okay?
Okay.
Okay, and then maybe we'll just hit one other person on this panel before we go to audience.
Yeah, so things to think about when picking certain vendors, is the scalability of the program, with supply shortages and supply needs, being able to have a program and having a company that's going to be able to grow with you. Having multiple options allows for a competitive market. So you have the option then of picking something that is feasible. So the feasibility, the funding sources that you have. What we've done locally is, partnering with certain companies. Public health historically has always partnered either, you have options of partnering with public or nonprofit, so profit and nonprofit. We've partnered with profit agencies during the COVID-19 pandemic. So looking at it from that lens, not necessarily public health having to always partner with nonprofit agencies, but really looking at what the test kit offers, what your program's able to fund, and how that internally works is not going to work for every single organization, because each of our landscapes and each of our populations we serve are different.
Okay. John, would you like to add anything to that, or?
Briefly, yeah, I mean, making sure that whoever's providing the service, that they can scale it up. I mean, sometimes these things go big quickly. There has to be really robust linkage to care. I think, looking at things that can maximize return rates, the data that you get back from the service is so important for surveillance and for helping to evolve the service and being able to work with your service users to make a better service.
Okay, great, thanks. So now we have about, it's like 18, 19 minutes for audience questions, or maybe a little bit less than that. Let's bring Dr. Vanderpool back out to join our panel. And there are 2 microphones in this room. There's one right here in front of the stage on the right and the left. So if folks have questions, please feel free to come up to one of the mics. And you can just line up. We'll try to get to all of your questions. Please let us know if there's any particular person to whom you're directing your question, or whether it's kind of open for anybody to address. Yes, please.
Great, thank you. Good morning. So I have 2 questions. The first is, my thought is folks who don't want to go into a clinic and access the traditional medical system, they'd rather be collecting or testing at home, might be apprehensive to then go and access treatment if they do get a positive test. So I'm wondering if folks have any data about treatment, the difference in people coming in to get treatment versus when they're getting tested in the clinic. And then my second question is for folks who may be sitting in the audience, they don't have a program set up and they want to go back to their state or their local health department. Kind of any ideas you have, who they need to talk to, and specifically if there's any political issues that you've encountered in setting up your program.
You want to take first question, Alicia?
So I already forgot your first question. I do apologize. It is nerve-wracking up here, but I think it was in regards to treatment. The current program and the current partners that we have, results are sent simultaneously to the health department and to the patient. As far as treatment options, individuals can utilize our 340B medications. We can have standing orders. We can send in treatment to local pharmacies of their choice. And then we also have the option of our disease intervention specialists providing treatment in the field with our 340B medication. So individuals don't necessarily have to return to the health department for those treatments. We also have EPT, expedited partner therapy, availabilities as well. I can't remember.
I think that's similar for Idaho, exactly mimicking Iowa's operational stuff. So,
what's interesting with our services in the north, if somebody tests positive for chlamydia in our service, then they've got the option of having the medication posted directly to their home address. 93% of those people opt for postal treatment. In the south, they're not allowed to post treatment, and so most of those people are referred in to clinic for treatment, or they can collect from a local pharmacy. Whereas all syphilis and all gonorrhea treatment, they are referred to the local clinic. And what's really important about that, generally people with syphilis and gonorrhea, you want to engage them, and there's lots of other things. They may need PrEP, they may need vaccinations. It's really good to get those people into clinic, but there's so much chlamydia out there that it's nice not to have a clinic full of people needing chlamydia treatment.
I'm not positive that both of those questions were fully addressed, so if you want to come back up and ask a follow-up question, please feel free to. And then here on the right, yes.
Great, thank you so much for a really thought-provoking session. My name is Nick Van Wagener, I'm from Birmingham, Alabama. The question that I have for you, maybe it's two questions. The first is in your screening, what proportion of positives are you seeing? Thinking a little bit about the yield on the screening aspect. And then the other question that I have is, as far as a follow-up on the treatment question, and that is what proportion of patients who are positive can you confirm receive treatment? Thank you.
Yeah, I mean, the asymptomatic screening for people who are worried well and don't have infections, I'm sure that's something that we kind of, as a cost implication. So go ahead.
I can speak for Lynn County. Our positivity rate for our remote testing program is about 7% of our individuals, and 100% of them have received treatment. We've initiated this program in April of 2022, and that data goes through March of 2024. So the last few months is not within that data, but we do have a good positivity rate of asymptomatic individuals, and we were able to connect with all of them to receive treatment, either through their primary care, through a pharmacy location, or through our clinic.
Charlie, anything to add to that?
So we work with a variety of partners, so I didn't pull all of that data for here. But I can say that for one of our partners, local health department, positivity rates have fluctuated depending on like how many people are ordering kits and getting tested, between 9 and 13%. So that's definitely a really good ROI. And then they're the ones that do the resulting and the linkage to care and treatment. So.
Thanks. John?
Yeah, certainly. I mean, across the whole of the UK and Ireland, positivity rates vary quite dramatically depending on which population you focus on. In my local area, we're running at about 14% chlamydia positivity in our under 25 population, so that's quite a lot compared to other areas of the UK. When you look at the same under 25 heterosexual population, about 3% gonorrhea when you include pharyngeal testing as well. And some programs do focus on the positivity rates, and they often look at sort of those programs where perhaps their positivity rates are much lower. But I think we need to also bear in mind that most people that I talk to who use online testing, they want to be told they don't have anything, and that really benefits their sexual health. And I think that when we have a narrow focus of what's important, it's not. I think bear in mind it's not just the absence of disease, that we really need to be looking at what people need out of online testing. And so it's not the lower positivity rate programs. It's not that they're not providing benefit to those people who are testing.
Esmeralda, anything to add about positivity or linkage? Okay.
Kind of similar.
Similar. Okay. Great. Yes.
This is a great panel. Thank you very much. Anatole Mellon Johansson from the UK. My question is around pooling of samples. We've got data showing that the pooling of samples is non-inferior to separate site testing, and clinically it makes little difference where the gonorrhea is in terms of treatment and partner services. And I'm just wondering, what can we do to, as a health equity, through that lens, do about making sure there's more pooling happening so that we don't have this cost differential between 3-site testing versus 1-site testing, and how could we move that forward?
It's something that we've got a lot of experience of in the UK. I mean, we've published a number of studies showing, not Preventex, but in my former life working in London, showing that if you're pooling throat, rectal and urine specimens, that analysing one specimen is obviously much lower cost and gives more or less the same results. We are looking at it for UK programs where it's a little bit easier. I think Bobby, if she was still on the panel, unfortunately I think she's had to leave because of her throat, but she would tell you that that would be very difficult in a US setting because of the validation and the regulations that will be limiting the use of pooling. But a pilot we did in Ireland recently, as I said, if you test the young heterosexual population's throat as well as their genital site, you find twice as much gonorrhea as you do if you're just limiting it to genital samples. So identifying that asymptomatic reservoir, I think, is really important. But the only efficient way of doing that, or the only affordable way perhaps going forward, is if we do look at pooled samples for testing. So
Take a question here, and then one here, and then that might be all that we have time for, but we'll see. Go ahead.
Good morning. Thank you so much. This has been an extraordinarily informative panel. Winoa Vikli with Access Health in New Mexico and El Paso. I would strongly like to emphasize the support for the idea of pooled specimens. We're familiar with the fact that the NHS has done that for some time and wish we had the option in the US. As an advisor to the adult film industry, a medical advisor, we've bumped up against resistance to self-testing because there's a concern that there's an opportunity to provide a specimen that would not be a genuine specimen, just submitting a swab that actually hasn't been utilized. And so I'm wondering, in a professional capacity, if there would be any sort of opinion about the validity of that concern, because it is a rate-limiting step for a number of the entertainers in that they're told they cannot self-test. They have to travel to a large metropolitan area to be cleared for work. And the fear is that somehow they're going to provide samples that aren't genuine and get cleared based on a non-existent specimen.
So if I understood, the adult film individuals are being discouraged from doing their own self-collect.
They're not, the test is not considered accepted by the trade association as permission to work. So you're required to test every 14 days, and you're not able to self-test. You have to provide the specimen in a laboratory setting. So there's no ability to do home testing or self-testing. And so there's this concern that somehow you're going to be able to provide an invalid specimen just so you can get cleared for work. You're not actually going to test yourself. And so I was just wondering if you guys had any, they're probably the most tested community in the country. They get tested on average 18 times a year, and they pay cash, but they're not able to access at-home testing.
So there might be potential workarounds if you talk to the testing site where people are supposed to go and ask for things that are maybe more local, that are considered clinical in one way or another. Gold standard when we're doing tests is to have some form of clinician on site, but really when you go to a doctor's office or a clinic, most of the time they're handing you the box and they say, go to the bathroom and swab your holes.
Yeah.
Right? Everybody can do this. So if there's a way that you could set up some kind of clinical partnership between sites that are closer, that's one way you could maybe bridge the gap.
I just wasn't sure if is there some way that people could game the system differently at home than they could in the doctor's office? Take the kit, swab your holes. Take the kit home, swab your holes. What's the difference?
It just may be educational to that adult industry in regards to the validity of some of the testing. So it just may be education to their company they work for, their agency that they work for, in regards to, because remote testing, it is a shift, it is a mindset change, but you also have to be able to trust your clients that you're working with to be able to do their self-collecting. So just maybe an internal process change within those agencies to allow for the remote or home self-collecting options.
So there's no technical way to game an at-home test differently than you would at a doctor's office?
Yeah, it sounds like no, and I'm afraid I'm just going to have to move us along. Sorry. Please feel free to stay. We have a break after this, so I encourage folks to stick around and chat more with everybody up here. But we're going to take a last question.
All right, thank you so much. Good morning, everyone. My name is Johnny Green III. I hail from the Michigan Department of Health and Human Services, where I serve as a priority populations coordinator. We have a special interest in self-collection and remote testing, and I guess my question is really directed towards Charlie. One thing I heard you say and I'm really impressed with is how you all target your remote testing with different types of priority populations. And I guess the question I have is, how do you all deal with the issue of return rates with the various organizations that are receiving these test kits? And do you feel like it's cost effective with those return rates that are a little bit lower than others? And then how is technical assistance provided to those patients that maybe have some issues with submitting their specimens?
Thank you for that question. So it depends on the partner that we're working with, right? We're a lab and diagnostics company, right? So a lot of community members don't know us, and that's where the intentional partnerships come in. When we work with our CBOs, they're the known and trusted value in community, wherever that is, right? So people are going to these CBOs for social services, potentially healthcare services, et cetera. So we create the algorithm for treatment, for seeing the clients and everything. And most of the CBOs, either they have us do the resulting or they do the resulting. But they, more often than not, are the ones resulting, and they have the relationships with the people so they can do the follow-ups. And then we have a tracking system set up so that we can see who hasn't submitted their kits, et cetera. And so then that's a dialogue with the community-based organization saying, hey, let's follow up with such and such a person. And so rates are pretty decent.
Okay. Do you all have specific timeframes where you utilize that communication with those patients, or just based upon that organization you're working with?
I didn't hear you, I'm sorry.
I'm sorry. Do you have certain timeframes where you do follow up with the patients, or does that vary from organization?
It depends on staffing and availability at the community-based organization, but it's normally within 3 days.
Okay.
So from a public health standpoint, we've partnered with a lab, and to answer your question in regards to return rates, it does take time for our nursing staff to reach out to clients that have not returned their test kits. There is that outreach either through an email, through a text message, through a phone call, and we will reach out to them at a 1 week and a 2 week mark if they have not returned their test kit. To be honest with you, I think our return rates are pretty good compared to the company that we've partnered with. The company we've partnered with indicates that their return rate for paying customers that have purchased this test kit is 12 to 18%, which is to me very low. Through our grant-funded program, these kits are free to our community members. Our return rate for the mail-in option is about a 48% return rate. Our return rate for individuals picking up a test kit from a pharmacy location, that is a 78% return rate. So our program's very successful in return when you're looking at it from a lens from a return rate, but we also need to look at it from a lens from a patient satisfaction as well. Do our patients like this option? Do our patients like the availability of being able to test at their own time frame discreetly in their own home? There's multiple lenses when looking at in regards to return rates and workflows, and each program is going to be different for each location.
Thank you so much. Looking forward to that session this afternoon.
We're going to wrap up now, but I just wanted to give our panelists a last couple of minutes very quickly to talk about something that you've all kind of touched upon already, which is kind of what your measures of success are. So, John, you said something about keeping some people outside of clinics that are kind of already working over capacity. We talked about some other kind of metrics of success that go beyond return rates. And so I just wanted to know from each one of you really quickly, remote testing is not more cost effective than providing services in brick and mortar settings in some places. And so, is this an effective strategy in which we should be investing a lot of resources? And how does this relate to your evaluation of whether these programs are successful? So we'll just go down the line this way.
I think return rates are important. We're usually over 80% with our programs in the UK, and there's a lot of ways that gets automated follow-up with text reminders and whatnot. But I think that looking at the success, I think you have to look at the success of the whole system. It's not just about looking at what online services have and bring and what your clinic-based services can do. I think it's about, if you combine online testing with the clinical service, looking at that overall system and hopefully seeing the benefits of the two of the systems working well together, and service users engaging with the service when they need to.
Okay, thanks, John. Esmeralda?
I think it's important to implement these new resources and assess how it impacts the public, the community. I think time will tell that we'll hopefully see an increase in numbers for STD testing in remote testing, and see an increase in completion of treatment and partner services. I think that this program will be successful and people are going to get tested and treated.
Charlie, your evaluation of a successful program hinges on what?
I think one of the things that makes programs successful is, we know that CBOs and health departments are hugely reliant on each other. The health departments have the money, and then the CBOs actually have the reach to our priority populations that we're trying to uplift. And they're also the ones that are providing the data and the reporting. Sometimes CBOs are working with antiquated software, like outdated electronic systems, and generating reports can be problematic. So it's super important that vendors recognize that health departments don't have unlimited funding and to make offerings available at as reasonable prices as possible. Also, I think that we've already seen that a different audience is being served by remote kits, right? These are people that might not have symptoms. They're curious about their testing. If they had symptoms, they'd probably be going into a location. So those additional costs, we need to start thinking that this is actually a thing, and it needs to be factored into budgeting and our frameworks.
You know, as we touched on earlier in regards to considerations of things being successful, we talked about return rates, we talked about patient satisfaction. Other things to consider when implementing, you know, it does take time for your staff to implement and roll out a remote testing program and to manage that system. We also know one-on-one education, that face-to-face interaction can help build those relationships with clients. However, the remote testing can also build that relationship and trust in the rapport with your local health department as well. So I don't see remote testing or home testing going away, but I also see that both systems complement each other. Really not as a replacement for that one-on-one brick and mortar appointment, but really complementing each other to allow our community members to have options. Other social determinants of health can be recognized when utilizing both systems as well. So with that counseling and that appropriate follow-up and treatment and piece as well. So, you know, in regards to remote testing, I think we're moving in the right direction.
Thanks so much. Thank you all. We're going to actually leave the stage now, but I do encourage you to stick around and talk to our panelists during the break and also look them up, their contact information through the conference site if you want to get more information from them. So thank you so much.
Please welcome back to the stage NCSD Executive Director David Harvey.
Don't leave yet. Hello. How was everybody this morning? That was a fantastic, fascinating session. I think a huge round of applause to Bobby, Preeti, and all our panelists, please. A couple of very important announcements as we close out this plenary session this morning. First of all, NCSD has its own remote testing initiative. We partner with many of you in this room on that program. We are currently working with something like 13, 15 jurisdictions. If you want more information on Check Yourself, go to our exhibit booth and find Keith Bird or Jessica Zamora. Keith and Jessica, are you in the room? Just stand so people can see you. They're in the back. Okay. Keith and Jessica, they'll tell you whatever you want to know about Check Yourself. I want to do a huge round of applause and thank you again to Roche and Debbie Hernandez. Debbie, I don't know if you're in the room, but thank you for supporting this session. Now, some important things I want you to know about what's happening during the next plenary at lunchtime. The first thing you need to know is you need to get here early and promptly after the breakout sessions. We're really squeezed for time. We want you to have your lunch, and then we want there to be more or less quiet in the room, not lots of clanking and things like that for lunch when the Admiral speaks. It is a very big deal that we have Admiral Levine joining us. Admiral Levine is the highest ranking trans woman ever appointed in the federal government. She will be here with us in person, and we expect, do not hold me to this, it's embargoed. We don't know for a fact this is going to happen, but we expect her to release the doxypep treatment guidelines during her talk. It's a big deal. So we want to honor her presence. She's doing very important work on syphilis, and that is going to be the topic of her presentation, plus the doxypep, we assume, we hope, guidelines. You can submit a question to be posted to the Admiral by looking for the QR code that will rotate through the screens. And you can also find a link in the app next to the lunch session. So there's a button there. You can submit a question. You can submit it anonymously. We're only going to be able to ask probably 2 questions, maybe 3. But the NCSD team will receive those questions, and we're going to do our very best to get through those questions that you submit. So once again, come early, eat lunch, then be quiet. Got it? You just follow instructions so well. Tonight is drag bingo. It doesn't say drag bingo in your program, but it's drag bingo. Bingo with a beat, drag bingo with a beat, and karaoke. And there is a certain someone who might make a repeat appearance tonight. Someone who's known for, at the instigation of Jessica Fraser Williams from California, singing It's Raining Men. No promises. That's at 7 p.m. Those are the announcements that I wanted to give to you as we close out this plenary. Please enjoy the breakout sessions. I don't know how you're feeling, but I'm feeling great, even though I'm not sleeping very much. But my energy comes from all of you. It's just great to see you all here and to meet you in the hallways and in the sessions. So enjoy the next breakout session, and then we will see you back here at lunchtime. Thank you.